Dr. Mason is with us. If we all watched the Super Bowl yesterday, and Thomas Davis. If you're listening, if you were online today, you saw that picture of his arm,
right? And
it looked like a football the way the sutures were put in there. What was that? What type of injury was that? He broke his forearm. Is that?
It's what's called a nightstick fracture.
And
it has that old term because a classic way to get it, depending on what circles you hang out in, is from a nightstick, or like a club, where someone swings it at your face and you hold up your forearm over your head to block it, and it hits the little finger side of your forearm and breaks the ulna, and that's what he had. He didn't get it that way, of course, but that's what it's called. Mid-shaft ulna fracture.
Mid-shaft ulnar fracture, and obviously non-displaced, not comminuted or whatever you described. Just
without
a hairline
having seen
fracture.
his x-rays, that's what I would expect. You obviously you can see them that are smashed all to bits, but you also see ones where they're just one little crack in the bone and it's in good position. And so something like this, it's an easy place to operate because that bone, in the areas where you're most interested, is right under the skin. So you can get to it without this big dissection and moving this out of the way and moving that. Not so much is in your way, which makes recovery easier for the patient because they're not having to heal muscles back down to bone. There's not so much dissection.
So it looks worse than it is.
Well,
it's bad.
It's bad enough if it's your forearm.
Right.
Well, it looks like it's 2 weeks at least. No more than 2 weeks post.
Well,
it looks It looks like an owie to me.
Yeah. Well, this is highly aggressive treatment.
Right.
But I think it's one of those things where you lay out the risk-benefit ratio to the patient, and obviously a guy who has a chance to play in the Super Bowl, who's also a linebacker. They're not typically shrinking violets.
Right.
Right. Yeah.
And he said, "Yes, I'm going to do that."
Hold it, but the plate they put in there, you described it as titanium.
My guess is it's a titanium plate. Stainless steel works just as well for many applications, but titanium could be a little bit lower profile, lighter weight, and probably faintly more flexible, which is a good thing in there. And you can see this long incision. They put lots of screws both above and below the fracture. So it's very classic, kind of old-fashioned treatment. But by old-fashioned, it's what's done. It's both modern, but it's technology that's been around for a long time.
Well, 30 years ago, 40 years ago, let's say a kid fell off the monkey bars at school. That would have been casted.
Right, but with kids, you cast them typically anyway. But with adults, even 30 or 40 years ago, a lot of these had plates put on, depending on what the fracture looked like.
Okay. And you talk about subcutaneous, so describe that. I know we're on radio, but that's easy access. You're not moving
subcutaneous just means under the skin. And so if you feel the bone on your forearm on the little finger side, you can feel it. It's right there.
Right.
And the point being is if you feel the bone on the other side, the radius, you say, well, wait, what's all this tissue between my skin? I can feel muscles and tendons. Stuff is in the way, whereas the ulna, not so much. And so it makes when you wake up in recovery, you say, gee, my arm hurts because I have an operation, but you don't have this feeling like, what did they do to me?
Right.
So it's no big deal.
Yeah, exactly. Yeah. Well, obviously, did you see the cast he played with? And to be back on the field, like I said, it's really aggressive. You talked about a mid-shaft fracture, and in the past, mid-shaft sometimes is a hard part of the bone to heal.
They can heal a little bit more slowly than diaphyseal fractures. And diaphyseal, diaphyseal is a midshaft, and metaphyseal that's near the ends of the bone, and sometimes the blood supply is a little bit greater there. Midshaft fractures can take their time.
And is it common, to take this metal out once you noticed on the x-ray this bone has healed? Are you removing this plate?
A lot of times you remove these plates because patients know they're there because they'll rest their forearm or something and they feel it, and it can be quite irritating. So it's quite common to take these plates out.
Wow, when does that happen?
Really, you could take it out anytime after it's healed. So if you had some reason to do so, you could even probably take it out at 12 weeks. But typically you leave them in, let's say, a year or something like that.
Huh. In a mid-shaft fracture like in the femur or like the tibia, the bigger bones, sometimes you do a rod. You insert a rod down inside the bone. This is not necessary here?
No, not here. You can rod an ulna, but this is typically a better technique.
Interesting.
Yeah, I was amazed. When I saw that,
and this will all be normal for him to play next year.
Yeah, my guess is that I saw the big pad he had in his forearm. My guess is that there's some deeper layer to that pad that's probably carbon fiber or something that's pretty stout, just essentially like a piece of armor. And with the different types of foam padding they had today, they probably had something that would, was really pretty effective.
He said in an article I read that his arm didn't even hurt after the game.
Yeah,
So everything was good.
Yeah, obviously this fracture didn't go all the way through, and like I said, it was. I mean, would you kind of describe it when you call it a nightstick fracture? Is it kind of a hairline?
Well, nightstick fracture just refers to a shaft fracture of the ulna, and doesn't comment whether it's multiple pieces or anything like that. This one, I'm just guessing from the description because he got it tackling someone, and a helmet or something like that hit him, and.
Is there any when the form, if this was a displaced or a what we call compound fracture, as a surgeon, I mean, there's a lot of nerves and blood vessels coursing through that forearm going into the fingers. Are you concerned when you see an X-ray where the fracture is completely broken about pinching a vessel or damaging nerve tissue?
Oh yeah, absolutely. It's it's part of just the most. You see a fracture like that, and the first thing you do is you start saying, okay. Is the patient neurovascularly intact? How are the nerves behaving? How is the blood supply behaving? And, in my career, I've done a few of these where you literally go in there and you say, okay, I'm putting the fracture together first because now we have something stable to work with, and then I'm repairing the nerve, and then the vascular surgeon is coming into the room to repair the damaged artery. And those are obviously much, much more severe injuries, but it's the first thing that pops into your head when you see the X-rays is how is the arm in general.
And so if you see an X-ray, I mean, obviously we're talking about significant trauma. You see an X-ray that you suspect that this bone fragment is maybe in a neurovascular bundle or an artery. How are you assessing that? I mean, you're just not on X-ray. You're doing another test, aren't you?
Right. You have to examine the patient and say, okay, can you move this finger this way, that finger that way? Can you feel this? How are your pulses? Is your capillary refill normal? Just a pretty typical trauma assessment. I mean, a lot of times the emergency physician is doing that before you even see them, and they're already on the phone to you saying, probably shouldn't finish dinner, probably should come right in.
Right, yeah. So let me ask you a question as an orthopedic surgeon. I mean, you're generally dealing with bones. You just described looking at nerve tissue, and when you look at nerve, if the nerve is lacerated, are you suturing that back together? Is that your job, or do you call in someone else?
It's typically your job if you're the guy who's there. Yeah, that's something that orthopedic surgeons do on a regular basis.
So describe that. I mean, just for our listeners, you got these two ends of these nerve roots, right?
Yeah, I mean, it's one of those things where with many fractures, if you have a nerve injury and the fracture's not open, you don't even explore it it's very much a case-by-case basis because in certain situations you say the nerve is likely to be damaged in thus such a fashion, it's likely to be irritated, stretched, and it's not likely to be torn. And so, you leave it be, you let it heal itself. But if you have a nerve that's divided by, let's say, a sharp trauma or a penetrating trauma, then you say, well, you need to get this in continuity to give it a chance to heal properly. And depending on how sophisticated you are and how experienced you are with nerve repairs, there are lots of different ways. Say, I'm going to do intrafascicular repair. You can work with the microscope or not. But with some of these, you're doing you're getting most of the way there just by saying, okay, I'm going to line it up properly and loosely suture it together and let the body try to heal this problem. And the range of effectiveness is tremendous. I mean, it ranges from, we think that helped a little bit, but there's still deficits all the way to nearly or essentially normal.
Fascinating. Once again, the body's fascinating.
Dr. Jeff Mason, everboneandjoint.com. How many surgeons do you guys have going there?
We have 8 right now.
8. Go to everboneandjoint.com.
I can think we have 9.
All right. 8 or 9 surgeons.
They're growing like
you just hired one yesterday.
They're just showing up. Thanks for coming on with us. We also want to thank Mark Brinkman, Officer Mark Brinkman. What a job he did. And Dr. Rosemary Peterson. Next Monday is President's Day. Does that stop us from doing a show? No. We'll be here.
Absolutely, we're going to be
Health
here.
Matters. Thanks to Tom Lafferty. Thanks to Karen Morick. I'm Maury Eskenazi.
I'm Shannon O'Kelly. Stay fit and stay healthy.